My name is Melissa, and I'm going to be presenting on multidirectional instability of the shoulder. So a basic rundown is instability of the shoulder in either 2 or 3 directions. So this can be anterior instability, posterior instability, inferior instability, any combination of the 3. And it can be caused by or it can result in a subluxation or a dislocation of the shoulder. And so the way that you really differentiate this from someone who's just lax in their shoulder is that they have to be symptomatic. They have to have pain, they have to have apprehension. And because it can be really difficult to diagnose and treat just because it's so general. The incidence and rates of it are really unknown, and across research and things like that, there's no uniform definition or diagnosis. There's no one way to really diagnose it. I found that it occurs equally in men and women, that athletes are more susceptible to instability, and that most of them are younger, so between their teen years and their 30s. And that it occurs often in swimmers, gymnasts, weightlifters. And because you have this instability that causes subluxation or dislocation, it can also lead to things like labral problems, impingement, bank guard, heel sacks, anything that accompanies those. So how it happens, we all know that the glenoid doesn't offer a lot of stabilization in the shoulder. So the muscles and ligaments have to provide all that stability. So it's caused by a lot of repetitive overuse, could be caused by acute trauma, and there are some studies do show that there could be a genetic predisposition to joint laxity. And because it can be caused by repetitive overuse, it can occur without any significant injury. So it could just be something that happens over time. And if you do have those subluxations or dislocations in the athlete, they may spontaneously reduce and just kind of take care of themselves. So signs and symptoms, they're going to be really lax, and they're going to have pain with that laxity. And they may be so lax that they can purposefully dislocate themselves. They may be able to pop their shoulder in and out of joint. And so they're going to have some significant humeral translation, possibly muscle spasm guarding, because they probably aren't going to want that dislocation to happen. Altered scapular and humeral mechanics, because we know that if you don't have a stable base, then that's going to affect everything else. They could have some extra mobility in their AC or their SC. A lot of their symptoms are going to occur at the mid-range of motion, because they're not really going to be going into those extremes, because that's going to cause problems, it's going to hurt. And so it's going to happen during activities of daily living. They could be reaching for something and their shoulder could pop out of joint. And the pain and their symptoms are going to differ depending on which direction they're unstable. So if they have inferior instability, they're going to have pain when they're carrying something. So imagine if you're carrying a heavy suitcase down by your side, that's going to hurt. And then if they have anterior instability, those overhead positions like an overhead athlete are going to be painful. So there are a lot of special tests that you can do. Some are better than others. You can do anterior and posterior load and shift, anterior posterior apprehension, fulcrum apprehension relocation test. A couple that I've never heard of, the Fukuda, the push-pull, supine stress, and then a sulcosine. So some that we've heard of, some that we haven't. Treatment for this, you're going to start out conservatively, immobilize, and you're really going to rehab all of your scap stabilizers and your rotator cuff and all the muscles that affect that. And while you're doing this, you're going to avoid any position that could cause a dislocation, because you don't want to dislocate while you're doing rehab. Obviously, you're going to treat with NSAIDs, possibly a corticosteroid injection, and as you're rehabbing, you want to go slowly, because if you go too quickly, you could create more instability in the joint. In some cases, surgical intervention can be helpful. They do something called an inferior capsular shift, which reduces the volume of the joint and thickens the whole capsule of the shoulder. And it has been shown to be very successful. However, it does require incision of the subscapularis, so there can be complications due to that.